our part of the world also. So we get a lot of case of gastric carcinoma. So it's very it's common in the more in the our part of the world and in Japanese people. Okay, so so the thing is that covering gastric carcinoma in a single lecture, it is quite difficult. Okay, so I'll try to concise it as far as possible, and because there are many things you need to know about gastric cancer. Okay, and so I'll just try to summarize. So in between, if I leave some slides and switch on to the other slide, then you don't get confused. Okay, and so let's start. So with regard to embryology, you know the how the foregut, midgut, and the hindgut is formed, and about the different part of rotation of the intestines. Okay, so after the rotation, can you see the dorsal mesentery, and you can how the lesser curvature, the greater curvature is formed, and this one being the lesser omentum. Okay, the lesser omentum, and this one being the greater omentum towards the greater curvature. Okay, so the lesser omentum, and then you see the lesser sac in this area, and the greater sac being the abdominal cavity. Okay, so the lesser sac and the greater sac is communicated by the foramen. Okay, here, so foramen of Winslow. So you can see the how the liver and the stomach and how it is related. Okay, the gastro so gastrosplenic and the lienorenal ligament. Okay, so all these things you must have read during your basic science. Okay, so now you can see the relation of the stomach, and this is the lesser momentum. Okay, so it's a lesser momentum, and then you can see the stomach here. Okay, so these things you already know. Okay, and okay, so now you if you see this picture, then you see there is a foramen of Winslow here, and then you can see the hepatogastric ligament and the hepatoduodenal ligament, which is known also as lesser omentum. So if you see here, you can see a space behind this, and you can see the stomach, the cardiac end of the stomach, and the fundus, the body of the stomach, the antrum, and the pylorus, and you can see the pyloric sphincter here, and then the first part of the duodenum. Okay, so the hepatoduodenal and hepatogastric ligament. You can see the foramen, which is just behind the hepatoduodenal ligament and portal triad. So it will go behind that and gets connected to the lesser omentum. So lesser omentum, the lesser sac. So lesser sac is connected to the greater sac, that is the abdominal cavity, through this foramen, and you can see the gallbladder, the liver. Okay, okay, so that's, and then you can see the spleen here and the the splenic flexure, and then you can see the hepatic flexure of the colon, and you can see the duodenum here. Okay, so this is the duodenum, and then so whenever you are operating on the stomach, you should know all these structures. So now you see the division of the stomach you have already known about. So we'll not go into that. See, this is a little bit of important, the gastroesophageal junction. So you can see the columnar line epithelium and the squamous epithelium of the esophagus. So you can see a line. So that is known as the squamocolumnar junction, also known as Z line. Okay, and then so this is so there are various definition of gastroesophageal junction. So you can see here clearly how the columnar epithelium and the squamous epithelium and is being separated clearly. And you can see the right gastric vein, which is draining into the portal vein, and he can see the pre-pyloric vein of Mayo. Okay, so that will delineate, that will give you the when you are operating on a patient. So that is pre-pyloric vein of Mayo could be the landmark to identify the pylorus. Okay, and then you can see the right gastric vein draining into the portal vein. Okay, so then from the right gastric vein, this pre-pyloric vein of Mayo, it gets drained into the right gastric vein. So you can see this is very important. So whenever you see the anatomy of the stomach, and as you can see the vascular supply, so you can see the celiac trunk here, the left gastric artery. Okay, the left gastric artery supplying the stomach and the lower end of the esophagus. Okay, okay, and then you can see the left inferior phrenic artery here, and then you can see, you can from the celiac trunk, the common hepatic artery is going into the, is going, and then the first branch will be the right gastric artery, then will be the gastroduodenal artery. So you can see the right gastric artery here, okay, which is a branch of common hepatic artery, and there is a artery known as gastroduodenal artery, okay, which goes behind the pylorus and the first part of the duodenum. Okay, and then from gastroduodenal artery, you can see there is a right gastroepiploic artery. And from, you can see there is a splenic artery here. Okay, the splenic artery here, which gives rise to a dorsal pancreatic artery. And the splenic artery again gives rise to left gastroepiploic artery. So the right gastroepiploic comes from the gastroduodenal artery, and the left gastroepiploic comes from the splenic artery. Okay, and the gastroduodenal goes behind the pylorus and the first part of the duodenum, and you can see, so the celiac trunk, the left gastric artery, the splenic artery, and the common hepatic artery. So these are the main branches of the celiac trunk, and the right gastric being the branch of the common hepatic artery. Okay, so see how it is, and then you can see the pancreaticoduodenal artery coming from the inferior pancreaticoduodenal artery coming from the superior mesenteric artery. So you can see here, okay, just before it goes behind the neck of pancreas, the inferior pancreas, sorry, the superior mesenteric artery gives rise to inferior pancreaticoduodenal artery. Okay, so so these arterial supplies are important because all the lymphatic drainage of the stomach will, this whenever we come to that, we describe in terms of these vessels. Okay, so this is how we have described the different types of the arterial supply. Okay, and if you see the venous drainage, you can see here the short gastric veins. Okay, the short gastric veins, they are draining into the splenic vein. Okay, and then you can see the splenic vein coming all the way, and then you can see the inferior mesenteric vein draining into the splenic vein, and it will finally combine with the superior mesenteric vein and forms the portal vein. So you can see the left gastric vein is draining, the right gastric vein is draining into the portal vein, giving rise to pre-pyloric vein of Mayo. Okay, and then you can see the pancreaticoduodenal vein draining into the superior mesenteric vein. Okay, so this is the about the anatomy, the vascular anatomy, and then you can see the lymphatics. Okay, so there are 16 stations described. Okay, so the 16 in 16 stations, so you can see that there are 4 zones which are draining. You can see this area is draining into the pericardial or the left gastric, and then this area into suprapyloric and infrapyloric. This area is draining into the gastroepiploic lymph nodes, right gastroepiploic and then this is draining into the left gastric bulb. So, and then finally they will all drain into the celiac group and the thoracic duct. So this is about the lymphatic drainage, but you have to know a little bit about the stations of the lymph node. Those are numbered from 1 to 16. If you see the layers of the stomach, where you can see the mucosa, you can see the mucosa here, where you can see the gastric, the pits here, and then these are the glandular structures here, and then the submucosa, and then this is there is a muscle layer, okay, which is the the muscularis mucosa, okay. So and then the muscularis propria, and then the serosa. So these are the various layers of the walls of the stomach. If you see the nerve supply, the left the sympathetic, parasympathetic. So the left is the left anterior. So the left is the anterior and the right is the posterior. So if you see the parasympathetic, you can see, and then if the anterior branch will give rise to hepatic branch, and the anterior nerve of Latarjet, and then the posterior will give rise to criminal nerve of Gracie, or and the celiac branch. So posterior will give rise to this. And then the sympathetic, you can see that the greatest flanking nerve from T5 to 9 gives rise to the sympathetic nerve system. And then you can see the enteric nervous system, where the Meissner's, that is the submucosal, and the myenteric, that is the oblique plexus, forms the enteric nervous system. So if you see about the different, so after a short introduction about the anatomy, and we see about the gastric neoplasm, okay. So if you see, when you call it a neoplasm, it could be a benign or malignant. But when you see, tell about the carcinoma, it is always malignant. So whenever you talk about gastric neoplasm, it is benign, that is epithelial, or the mesenchymal origin, or malignant. So that could be an adenocarcinoma, or a gastrointestinal stromal tumors, or the lymphomas, okay, or and secondary from the invasion from the adjacent tumors. Are you listening to me? Yes. Are you understanding it? Yes, and everybody is listening.
Sir.
Uh,
Yes,
yes.
sir.
Okay. Okay. So, okay. No problem. Okay. So then, whenever you talk about the gastric neoplasm, the benign tumors, it could be the gastric polyps. Okay. So the gastric polyps, and 47% of the the fundic gland polyp constitute about 47 percent of all the gastric polyps. So usually they are seen in the fundus, okay, and they are usually hyperplastic polyps, and and then you can see there is a syndrome known as familial adenomatous polyposis syndrome, or the Gardner syndrome, where the 53% of the patient will have gastric polyps. So whenever you correlate with a syndrome, then it will be a familial adenomatous syndrome, polyposis, and you call it a Gardner syndrome. Okay, so in this patient, you will mostly see the gastric polyps. Most of them will be hyperplastic. Okay, so the hyperplastic polyps are more frequently observed gastric polyp, and they occur in up to 20 to 28 to 75%, and they usually occur in the setting of chronic atrophic gastritis. Okay, and only adenocarcinoma is detected in about 2% of the cases. So if you talk about adenomatous polyps, they account for only 10% of the gastric polyp, and they are usually solitary. So that's the difference. If you see about hyperplastic polyp, there are multiple polyps. If you see in a patient with familial adenomatous polyposis coli, and then if you do an upper GI endoscopy or a gastroscopy, in that you'll see multiple polyps, which are hyperplastic polyps, and you'll see it in the fundus of the stomach. And but if it is an adenomatous polyps, they are usually solitary, sessile, and they are in the antrum. So 10% will be malignant. So if the polyp is more than 4 centimeter in diameter. So they harbor carcinoma in about 40% of the cases. Okay, so it is more dangerous to get a adenomatous polyp, which is more than 44 centimeter, uh, rather than getting multiple hyperplastic polyps seen in various familial adenomatous polyposis syndrome. Okay, so treatment will be the endoscopic polypectomy. So that could be that is the definitive treatment after you do an upper GI endoscopy and then take a biopsy, and we know that it's a benign polyp. So if it is more than 2 centimeter and it is sessile type of polyp, then you may have to have an surgical excision. Okay, and then you follow up the patient with serial endoscopies. So now we'll go into the carcinoma stomach proper, okay, where carcinoma stomach is a major cause of mortality worldwide, okay, and uh, so the prognosis is little bit poor if the tumor has spread. Okay, so if you do an TNM staging of the tumor, in that if it has invaded the muscular wall and the lymph nodes are positive, in those sort of situations, the prognosis is little bit poor. Okay, when the tumor has progressed more, and about 15% results are obtained in Japan, better results, because they do screening endoscopy or barium studies. Okay, so they will detect the early tumor and operate on the patient, and the prognosis are better in the Japanese setup. So Japanese people have done a lot of work with regard to carcinoma stomach, and the results what they have got is better than the rest of the world. So if you see the incidence of gastric carcinoma, see, you can see that Japan has the highest incidence. Okay, followed by Europe, and in UK, and then the lowest in USA. And the magnitude of the problem, you can see, is the fourth common cancer in men. It's initially by lung, prostate, then colorectal, then stomach. And in female, it's the fifth most common cancer: breast, cervix, colorectal, lung, and stomach. So it is like that. And then it's the second most common cause of cancer death. Okay. Yeah. And sorry. So if we talk about the risk factor, then the predisposing factor, you can see here the pernicious anemia or the atrophic gastritis, previous gastric surgery, chronic peptic ulcer, smoking and alcohol. Environmental factors like Helicobacter pylori infection, which will give rise to a relative risk of 6 to 9 fold, okay, and low socioeconomic status, Japanese nationality, and diet. And in genetic, you will see the blood group A patients and patient with hereditary non-polyposis colorectal cancer syndrome, HNPCC. So these are the various risk factors. Okay, and associated factor which increases the risk is nutrition, like high salt consumption, high nitrate consumption, low dietary vitamin A and C, smoked and salted food, lack of refrigeration, poor drinking water like well water, and the occupational factor like rubber worker, coal worker, cigarette smoking, S. pylori infection, Epstein-Barr virus, radiation exposure, prior gastric surgery. Okay, so all those other factors which I have listed already. Okay, and the family history. Okay, and the adenomatous gastric polyp. Can you see that? And then the dysplasia and intestinal metaplasia. Okay, okay. So nutritional, yeah, and then also high complex carbohydrate consumption and low fat or protein consumption. Okay, environmental, again, I have already told you. So these are all done. Okay, so if you see the relation of Helicobacter pylori and gastric carcinoma. Can you see the Helicobacter pylori residing in the stomach where the pH is 4.5 to 9, okay? And it's the most frequent site of colonization is antrum, okay? And you can see how does the Helicobacter pylori, with the help of CAG-A gene, it will lead to, chronic superficial gastritis, atrophic gastritis, intestinal metaplasia, and here, after intestinal metaplasia takes place, the mutation. So here, you see the genetic factor comes into it. The P53 gene, okay, and COX2 overexpression and cyclin D2 overexpression, decreased expression of P27, and microsatellite instability. So all these factors will give rise to dysplasia and finally the cancer. Okay, so proton pump inhibitor and gastric cancer. So proton pump inhibitor initially blocks the hydrogen potassium ATPase pump, giving rise to hypergastremia because what will happen is there will be decreased acid secretion that will give rise to increase in gastrin secretion. Okay, so that for increased gastric secretion, you need hyperplasia of G cells and enterochromaffin-like cells. Okay, and then carcinoid, and that will give rise to, the so in the patient with S. pylori on long-term PPI, low acidity environment allows bacteria to colonize in the gastric body, leading to corpus gastritis. Okay, and 1/3 of the developed atrophic gastritis. So the PPI use will give rise to all these things. So it's also long-term PPI use is not good for, because it may give rise to hyperplasia of the G cells, leading to hypergastrinemia and finally giving rise to various tumorous conditions. So if you see, the nowadays the incidence of gastric cancer has progressed to the proximal part of the stomach. So see, you can see the cardia of the stomach, and the esophageal gastric junction and the lower esophageal carcinoma. So all these forms about 60% of the, the gastric cancers involving the esophagus, leading to the involvement of the stomach, or starting from the stomach giving rise to the involvement of the lower end of the esophagus. So it has progressed because people use a lot of proton pump inhibitor and S. pylori eradication medications. So it has reduced the incidence of gastric cancer in the distal part, like in the antrum or pylorus or in the body of the stomach. So the histological types of gastric cancer like adenocarcinoma, lymphoma, GIST, squamous cell carcinoma in very less case, and then the carcinoid, and so various types, and in adenocarcinoma being the commonest. So these are the histopathological findings. So you try to learn about the the histopathological finding where you can get the diffuse type of carcinoma. So I'll tell you about that, okay, later. So there are various pathological classifications: Bowman classification, Lauren classification, and WHO system. In Bowman, you can see the various types. This you can find it in Bailey and Love. So the protruder type, then the ulcerative, then the infiltrative, then the diffusely infiltrative, and the fifth one cannot be classified. So the 2, 3, 4 is the depressed type, and type 1 is the protruder type. That's a Bowman. And then Lauren classification is, again, I told you about the intestinal and diffuse type, where the diffuse type, it is usually seen in younger age group. Can you see that? It's here. It's a younger age group, and it is poorly differentiated. So very young patient, and then it has got a familial tendency. Okay, diffuse type of, so it has got very poor prognosis. So I have seen few cases where the the two generation of family members have developed gastric cancers, the diffuse type, in very young age, and the second generation has got it even younger than the first generation, in around 13 or 14 years, where you do a prophylactic gastrectomy for those patients. Suppose the parent has got the diffuse type of gastric cancer in their family, and then if they come the cathedrin positive, and so in those cases, and if you do a genetic testing and they find it that it is a diffuse type, familial type of cancer, in those age group, you do a prophylactic. So if you, without patient developing a gastric cancer, you remove the stomach, and so that is known as prophylactic gastrectomy. So you prevent it from occurring. So WHO classification, again, adeno, squamous, undifferentiated, and unclassified. Okay, and there is one more classification, that is Japanese classification of early and advanced type of gastric cancer. So these all classifications you will get it in the in Bailey and Love or the Savitson textbook of surgery. Okay, and then the spread of gastric cancer. So it can be a direct spread, or the lymphatic spread, or the blood-borne spread, or the transperitoneal spread. Okay, so most of the is the lymphatic spread. Okay, so what happens is two things we have to be a little bit careful. It can initially it will spread through the lymphatic route, and then there is also a chance of direct spread. Direct spread occurs because the stomach is just resting on the pancreas. So, and there is high chance that it will involve the pancreas, and also the stomach is very close to colon and the liver. Okay, so what will happen is that it will involve the pancreas and the colon initially, and then the liver also sometimes. Okay, if the tumor is in the lesser, towards the lesser curvature. So that is direct spread, but the commonest one being the lymphatic spread, where the perigastric group of lymph nodes are involved. So if you call a perigastric lymph nodes, that is the station 1 to 6 is also known as perigastric lymph nodes. So station 1 is the right cardiac, 2 is the left cardiac, then the 3 along the lesser curvature, 4 along the greater curvature, 5 is suprapyloric, 6 is infrapyloric. So 1 to 6, that is perigastric. Perigastric means within 3 centimeter from the border, lesser curvature and the greater curvature of the stomach. Okay, so within 3 centimeter. Okay, so that way it is like okay. So that's about the lymphatic spread, and then so the perigastric nodes. Okay, perigastric nodes will get involved. Perigastric node will get involved. So that is station 1 to 6. 1 to 6 nodes, perigastric nodes will get involved. So the station 1 to 6, and then the from station 7 onwards, it will be the second tier of lymph nodes. Okay, so from station 7 onwards, it is the second tier of lymph nodes which will get involved. Okay, so if you say it is suppose it will come after some time, that if you do a D1 resection. D1 resection means you are removing the perigastric nodes on that location. Okay, perigastric nodes that is within 3 centimeter from the border of the stomach. So remember this. This will frequently come into your, whenever you read book, then they will talk about the D1 resection and the D2 resection. Okay, so D1 resection means you remove perigastric nodes, and the D2 resection means you remove the nodes along the named vessels. Okay, so we remove the nodes along the named vessels. So that I have showed you already, the left gastric, the splenic, the common hepatic, and behind the hepatic there will be portal veins. Okay, the common bile duct, the proximal splenic, the distal splenic. Okay, and the various other groups of lymph nodes are there. So you just remember that perigastric, removing perigastric nodes means that is D1 resection, and then removing the along the named vessels will be a D2 resection. So now the standard for resection of the lymph nodes along the stomach in gastric cancer is the D2 resection. Okay, so the lymphatic spread. So the Versto's lymph node, that is also known as a Trougier sign. Okay, Trougier sign. So in that, what you see is that the left supraclavicular group of lymph nodes are involved because of the lymphatic spread. So the lymphatic spread from the celiac group will go into the lymphatic duct. That is the lymphatic. So it will go into the lymphatic system, and from there it will go into the left supraclavicular group of lymph nodes. Okay, so the thoracic duct will lead it to the left supraclavicular. How it will lead? Because the thoracic duct will drain into the left junction of the left subclavian and the left internal jugular, uh, the vein. Okay, so at the junction of that, the thoracic duct will drain there. So from the celiac nodes it will go into the thoracic duct, into the junction of the jugular vein and the subclavian vein. So what will happen is that when the lymphatics tries to drain there, because of the flow of the venous blood, the malignant cells get refluxed back into the left supraclavicular area, and there will be the tumor deposit. So that is the pathophysiology, how the left supraclavicular lymph nodes gets involved. Okay, and then as you know that since it is a vascular organ, you will get a blood-borne metastasis, and you will get a transperitoneal spread. Okay, so transperitoneal spread you will get where if it gets deposited into the ovaries, bilateral ovaries, it is also known as Kuchenberg's tumor. So if the tumor gets, it gets into the umbilicus. So if you see a tumor nodule into the umbilicus, you can see from outside. So it is also known as Sister Mary Joseph nodule. Okay, so that's about the transperitoneal spread. Okay, so depending on the location of the tumor, you see where all it gets, the nodal metastasis: upper third, middle third, and the lower third. Okay, so how frequently it gets? So if the tumor is in the upper third, and it is very rare to get a lymph nodal metastasis into the porta hepatis. Do you understand that? So depending on the location of the tumor, the metastasis will be. So similarly, you'll remove the D1 and the D2 group of lymph nodes. Okay, so the draining lymph nodes. So the most common clinical presentation, as you can see, that is epigastric pain, bloating, nausea, vomiting, already satiety, dysphagia, anorexia, weight loss. See, weight loss, this is one of the most common presenting, symptoms of the patients with any malignancy. And sometimes the patient can come with upper GI bleeding, or the patient comes with a history of melena, or or the patient can come with anemia, so could be an iron deficiency anemia. Okay, so whatever you said that new onset dyspepsia after 55 years with new onset dyspepsia or how he has lost weight. Okay, you see a CT scan of this patient, you can see that the tumorous deposits in the umbilical nodule. So as I have said that the consensus guideline, more than 55 years with new onset dyspepsia or those with alarming features. Okay, so should have an urgent gastroscopy within 2 weeks. Okay. So screening of a gastric cancer. Okay, these are so Japanese people are more they are doing more and more of screening. Okay, and then they do a lot of upper GI endoscopy or double contrast barium radiograph. Okay, upper GI endoscopy means gastroscopy. Okay, so they diagnose stage 1 disease so that it gets cured. There are other screening programs also. There are other screening programs also where what you will do, you will always tell that I'll do an upper GI endoscopy or a gastroduodenoscopy. Okay, so nowadays nobody is doing the contrast barium X-ray to diagnose a case of carcinoma stone. You can see the upper GI endoscopy findings where you can see an ulcer, okay, which is there, and then you can take multiple biopsies. You can see this is a white ulcerated area. This is also ulcerated area with surrounding edema is there. And then here, this looks like a malignant gastric ulcer. This also looks like malignant gastric ulcer. And if you see the double contrast, so you can see the gastric ulcer with radiating mucosal fold towards the ulcer crater. Okay, You can see that. Okay. And you can see here the pyloric stenosis. So in the antropyloric region, there is a growth which might have caused the pyloric stenosis. You can see here, see this is the fundus, this is the antrum, and in between, in the corpus of the stomach, there is a stricture, narrowing. So you may, so these are the various contrast X-rays which will tell you about the different types of stomach ulcers. So to diagnose it completely, you have to do an upper GI endoscopy. So if you see this, Linitis plastica is like something like this, where there is a diffuse infiltration of the stomach, okay, and then it's a very poor prognosis, and the stomach looks like this. Okay, so upper GI endoscopy, yes, it's a gold standard, and you can see benign and malignant lesion, and benign gastric ulcer, okay, and then okay. So now the thing is about the staging of the tumor. Okay, so read about the different stages. T1A, where it involves the mucosa, T1B, where it involves the submucosa, and then beyond that will be the muscularis propria involvement. So when it goes beyond the mucosa and the muscularis mucosa into the submucosa, and then it will go into the higher stage, okay, where it involves the muscularis propria. Okay, so read about the TNM staging. So N is, so when you talk about the pathological stage, so N1 is 1 to 6 nodes, N2 is 7 to 15 nodes, and N3 is more than 15 nodes. So whenever you have done a surgery, and then what are the nodes that are involved, and then what the minimum 15 nodes you have to take out when you are doing surgery, and then so if there are 1 to 6 nodes involved in that specimen sample, you call it N1, and then N2 and N3 respectively. So just have a look on this slide. Okay. Okay. So minimum of 15 nodes are required to be removed. So accordingly, the staging. So staging of gastric cancer is done by physical examination, the blood tests, and the imaging. So whenever you talk about imaging, it gives the proper staging of gastric cancer. So imaging means you can do an contrast enhanced CT scan, CECT. Okay, contrast enhanced CT scan is used as an imaging modality of choice for diagnosing, or sorry, for staging the stomach cancer. And nowadays there is something known as EUS, so endoscopic ultrasound. So in the tip of an endoscope, there is an ultrasound probe which is used, and then this ultrasound probe will, what it will do is, it will take care of, it will do an ultrasound from inside the stomach. So there is an endoscope which is inserted into the stomach, and then from there you can see the different layers of the stomach. As you do an ultrasound from outside of the abdominal wall, it will go inside the stomach, and then so it is attached to the endoscope. Okay, so you can do an ultrasound and see how much the layer, the mucosa, submucosa, then the muscularis propria, the serosa, what are the layers that are involved, and the perigastric nodes, how much is involved. So you can actually stage the disease by doing an endoscopic ultrasound. But since stomach is a very big, it's like a balloon, and it's a very redundant type of structure. So doing an accurate staging by endoscopic ultrasound may be difficult in case where it has done a stricture, the tumor has made a stricture, you are not able to pass the scope beyond the stricture, in those sort of situations, and there is a lot of food material inside. So in those sort of situations, endoscopic ultrasound may not be appropriate. So in that case, the CCT abdomen is the modality of choice. Okay. So this I have already told you. I'll not go into the esophageal-gastric cancer junction tumors because this might have been told you during the when the esophageal malignancy will be taught, okay, or might have been taught already. So in that you will know about this esophageal-gastric cancer EG junction tumor, okay, where the Seward's classification is used in those situations, and which also includes the gastric cancer. So this I'll not go into detail. Okay. See, I have told you about the different stations. Can you see that? So station 1, 2, 3A, 3B, 4, 4SA, 4SB, okay, and then 4D, 4D. So along the named vessels. So just remember 1, 2, 3 along the lesser curvature, 4 along the greater curvature, 5 suprapyloric, 6 infrapyloric, 7 left gastric, 8 common hepatic, 9 celiac, up to here, okay, and then will be 10 will be the proximal splenic, and then 11 will be the distal splenic, okay, 12 will be the periportal, okay. So remember these ones. So we'll most of the times we'll remove up to from 1 to 12 depending on the location of the tumor. So that will give rise to the D2 resection. Okay, so remember there are up to 16, but for our purpose we need not remove up to 16. If we want to do an D2 resection, we need to remove no up to 12. Okay, but remember what are the other 4, 16. Okay, it's given there in Bailey and Love or the Sabiston textbook of surgery. Can you understand now, right? Okay. Okay, see this 12, 13, 14, 15, I'm not going to discuss this. Just have a look in your textbook, okay, so that you understand it, okay. So up to 12 is important for D2 resection, but if you go beyond that, that will not be a D2 resection. It will be more than D2 resection. Okay. This I've already told you, EUS and CT are the primary radiological staging modality. Okay, so they can be complementary sometimes. See, in endoscopic ultrasound, you will see a picture like this. Okay, so where you can see from the center there is a circle in the circle in the center where you can see the probe, and then that is the location of the probe where, and you see the different layers of the stomach. Okay, so it is mentioned. It's mentioned that it will show the 5 layers of the stomach. So find out from textbook what are those 5 layers, which is seen in the endoscopic ultrasound. The CT scan, again, it will give rise to the proper staging of the tumor. See, you can see here, see the antropyloric, so there is a tumor. There is a tumor in the proximal body of the stomach. Okay, so this could be a G junction tumor which has involved the esophagus. You can hardly see the esophagus here. This is the location. The arrow will be the location for the esophagus, and then you can see that it is involving the stomach. So from this picture, we cannot, only one picture, you cannot say that whether the stomach cancer has involved the esophageal esophagus, or it has come from the esophagus. The epicenter could be the esophagus, and it has involved the stomach. Okay, so this is a type of tumor. Okay, okay, this is a type of G junction tumor. So CT will give you the metastatic staging also. So let's not go into MR staging, okay? So MRI is really used for staging of stomach cancer. PET scan. PET scan is not used most of the time for gastric cancer because only 50% of the gastric cancer will take up the whatever or the marker you will use. Okay, so whenever you do a PET scan, you have to inject a marker where we use a FDG, fluorodeoxyglucose. So in that, the stomach will not take up that. Okay, so it is not PET avid, we call it. Okay, so whatever contrast we use, and then the radiological tracer we use, so that will not be taken by the tumor cells. So the PET scan is not routine for the stomach cancer. See, laparoscopic staging. So before knowing that whether the tumor is operable or not, so what will happen is, if you do a diagnostic laparoscopy, you put a laparoscope, you put the patient under anesthesia, put a laparoscope and see initially into the peritoneal cavity whether the stomach cancer has spread already. So if you do a surgery at that stage, it may not be beneficial for the patient. So our diagnostic laparoscopy is to avoid the laparotomies. So you do a diagnostic laparoscopy in about up to 25% of the patients. You avoid the unnecessary surgery for the patient. Okay, so diagnostic laparoscopy, you see the liver, you see the peritoneum, you see whether the patient has developed ascites or not. Okay, in those sort of situations, in those sort of situations, you do a diagnostic laparoscopy. Okay, but the thing is that if you see some ascites or the peritoneal nodules, or if you see the liver metastasis, or it has involved the surrounding structures very badly, in those sort of situations you can avoid surgery. So only a small hole will be there where you can see, as you do a cholecystectomy, you put a camera through the umbilical cord and see whether the tumor is there or not. So I'll not go into Seward's classification. Okay. So you need to understand, I'll stop it here today. I need one more lecture class to complete this carcinoma stomach, because treatment part, I want to tell you a little bit about the treatment, that is the surgical resection and the adjuvant chemotherapy. Okay, so try to read it from the book, but the surgery and the adjuvant chemotherapy, I'll ask for one more class in due course of time. Okay, so that will be all right for you, I think. So maybe the next week I'll take one class for you with regard to the surgical therapy and the neoadjuvant and the adjuvant chemotherapy. So just see, there is what is the R status. R status means that R0, R1, R2. So whenever we operate on a patient, any patient with cancer, we want to do an R0 resection. Okay, R0 resection means we want to be a microscopically margin negative resection. So whatever margins you have taken, suppose there is a tumor in the antrum, and then you have gone 2 centimeters distal to the antrum, and you have put a stapler in the first part of the duodenum, removing the antrum and the pylorus. So you go 2 centimeters distal to the tumor, and 5 centimeter proximal to the tumor in the body of the stomach. Okay, so this much of margin is essential to get an R0 resection. So if you have done R0 resection, how you'll know it? You'll initially during surgery, you'll see through with your eyes whether there is an R0 or not. And then when you get a final pathology report, then you will know that it is an R0 resection. Okay, so after the final pathology report only, you know that it's an R0 resection. So your always target will be bring an R0 resection, not R1, not R2. Okay, those will be the palliative treatment. Whenever you deal something called palliative surgery, where the patient is bleeding profusely or the patient have an obstruction, in those sort of cases only R1 or R2 dissection is justified. Otherwise, you have to do an R0 resection. Okay, so the thing is, everybody is listening now? Yes?
Yes, sir.
Okay, so see, so go back and read your books. So read about carcinoma stomach, and then in the next week I'll complete about the neoadjuvant, adjuvant treatment, and the surgical treatment. Okay, so that will require half an hour more. So today I won't be able to finish it. So for next, so go back and read in your book, and next week I'll ask for one more class so that we can talk about the various forms of treatment modalities. Okay, that's all right for now. Is it all right?
Sir,
Yes.
त्यो TNM classification of tumor stage migration भनेको के term हो?
Oh, okay, okay. So see, okay. That I okay. It's all right. Stage migration means what will happen is when you do an inadequate surgery. Okay, okay. So whenever you do an inadequate surgery, and what will happen is that the all the lymph nodes comes positive, and you have done an inadequate lymph nodes removal. So that situation is known as stage migration. So we'll talk about stage migration phenomenon. Okay, when I talk about the surgical aspect. Okay, so I'll tell you detail about the stage migration when we talk about the surgical treatment and about the adjuvant and neoadjuvant treatment. Okay.
Okay, sir. So अनि blood group A मा किन common भएको cancer, gastric?
Okay, it is found like that, man. It is like people who take a lot of salt, high salt diet, and then people who are blood group A, so they are more susceptible for stomach cancer. But it is an unknown phenomenon. Those are only minor risk factors. Okay, so the blood group, being a patient of blood group A, doesn't predispose you for stomach cancer, but the thing is that in various studies, in various randomized control trial, where they have listed all the patient of carcinoma stomach, and then they have seen the various, they have tried to find the different various risk factors for the carcinoma stomach. Okay, in those sort of situations, what will happen is that they have studied various aspects, and in that they have found that most of the patient with blood group A were found to have stomach cancer. So these are the unknown reasons why.
Okay, sir. Thank you, sir.
Okay. Yes, yes. Okay. So next class we'll talk more about the treatment, neoadjuvant, adjuvant treatment, and the various things associated with it. Okay.